Hi, everyone, and welcome to ABCs of Anaesthesia on YouTube and on our podcast. And again, we have a live Viva episode with Stephany that's coming up right away. Hey, Stephany, how's it going?
I'm good. Thanks, Ligure. How are you?
So thanks very much for joining us. And obviously, it's a really big help for people actually around the world who actually listen to this stuff and just hear us chatting about these situations, which is, it sounds daunting, but they're really appreciative of us having these chats about what we do for cases. So yeah, thanks for coming along.
No, that's all right. So I just found out I got a Viva yesterday, which is exciting news.
Oh, well done. Excellent.
Yeah.
This could be pretty
50%
awkward.
of the job done.
Yeah, that's right. This could be a lot
Yeah,
more.
right?
Otherwise.
Yeah, no, I will have to call you before. Yeah, no.
Hey, Stephany, so tell us a bit about yourself. Where are you based? What's your training situation?
I'm a 4-year registrar at an APN hospital. What else can I say?
And that's in
it's very
Brisbane.
hard. Sorry?
That's in Brisbane, is it?
No, it's actually New South Wales, and it's where all the COVID cases are around.
Oh, I'm
All the
sorry.
COVID cases. So it's being a bit stressful lately, but it's getting better, which is good news.
Our hospital just became a COVID stream hospital, so we're doing all the training and ramping everything up, and yeah, it's all I can think is we're going to look back on this time, and we'll be proud of what we've done.
Yeah, exactly. Yeah, so I see it.
So, have you had many practice Vivas?
Yes. So as soon as I finished my written, I took a week off studying, and then I was trying to ask for advice about how to start preparing for the Viva, and all advice I got, it was like, you just get Vivas from people.
Yep.
So I started. But my feedbacks were, too disorganized, too messy. And it wasn't until I attended your bootcamp that I realized, okay, it all makes sense now. You just have to have a structure for everything, and that's how it works.
Excellent, great. So we'll work on that. And I might even do this if on the off chance you don't give me a structure for a structured question, I might just go, hey, Stephany, structure, and then we'll step back and just to practice it.
Yeah.
So good. I think that's pretty fair. That's a good thing to work on. So I might just put this into the chat now. And this is your STEM, and I'll read it out as well. And would you like a minute or so to think about that?
Yeah.
Okay, good. So just for everyone, our clinical situation is a 60-year-old male for an L3 to L5 lumbar laminectomy. And you see this patient in the pre-admission clinic. The patient is 150 kilograms and 170 centimeters, so a BMI of 51. Patient has diabetes, maybe obstructive sleep apnea. The patient is a smoker and also has hypertension and had a previous lap band, one of the weight loss surgeries, and has lost 30 kilos since that 2 years ago. And the question is, what is the definition of obesity? So sometimes these questions are quite direct, and this is going to be one of those times. So I'll give you about a minute, and then we can have a chat. Hey, Stephany, so that's about a minute. And this doesn't happen in the actual exam, but what did you write down during that reading time?
So I was trying to imagine what the next question would be. My feeling was that probably you will be asking what are the effects of morbid obesity in on my anesthetic for this patient. So I start writing about the different systems affected. And what will I say if that was the question? And how will I target that?
Yeah, that's fair, because that would be a very broad thing. Might as well get some things some things written down. Excellent. So, candidate, do you understand the question? And if so, please continue. What is the definition of obesity?
So obesity is considered a BMI of more than 30. There's a new WHO classification where 30 to 34 is a class 1, and it's also an ASA 1. 35 to 40, it's a class 2 obesity, and also ASA 2, and class 3, it's more than 40, and also ASA 3.
Fantastic. Now, what do you want to know on assessment in the pre-admission clinic?
I will, so as part of my assessment, it'd be in terms of history examination and investigations and potentially consultations. So I want to find out further, apart from my standard anesthetic assessment in terms of medical illnesses, medications, allergies, and previous anesthetic issues, I want to investigate further about his diabetes and glycemic control, whether he's on insulin or oral antiglycemic, and whether he's got any micro or macro vascular complications. There is potential for OSA as per the STEM. So I will ask if he had a formal sleep study and if he's required to use CPAP. And I will perform a stop bang score, which I suspect will be high on this patient. He's got significant risk factors for ischemic heart disease, being obese, diabetic, and hypertension. So we'll ask for active signs, symptoms of active cardiac disease, like syncope, arrhythmia, chest pain, palpitations. I will inquire if he previously have any a heart attack or a cardiac event. I will also ask about his smoking history, how many cigarettes per day, and what is his pack year history. And finally, about the lap band, 2 years ago, I will ask if there are still symptoms associated to it, because a common side effect of this is reflux or regurgitation, which put this patient at high risk of aspiration. Then I'll move on to my examination. In addition, for my standard airway assessment, I'll be concerned. I will look for features that make me feel that this patient is difficult to back mask ventilate, difficult laryngoscopy, and I'll potentially assess him for front of neck access. I will assess his vital signs, and I'll also look for right or left ventricular dysfunction signs, such as edema, increased JVP, crepitations. I will listen to the chest looking for wheeze. I will assess, I forgot to mention, but earlier, I will assess whether his obesity is central, which is commonly associated to more comorbidities than peripheral. Finally, in terms of investigations, I will request a full blood count, UEC, a group and hold, a HbA1c, an X-ray, not only to see lung fields, but also to look for cardiomegaly. I will organize an ABG, because I'm suspecting OSA, and also request a spirometry, ECG, and potentially an echo if there are features suggestive, if any of the above findings are normal.
Okay.
Yeah,
now, you find on your assessment that the patient has very little exercise tolerance. So they can't walk up a flight of stairs, they get very, very short of breath, and they can barely walk 50 to 100 meters without stopping. What do you do with that?
Well, with obesity, it's a bit difficult to determine what is the cause of this decrease of functional status. Doesn't necessarily mean cardiovascular or respiratory function. But if any of the previous tests like ECG, ABG, or spirometry are abnormal, I will refer this patient, in addition to the findings you mentioned, I will refer this patient for a cardiopulmonary exercise testing and cardiology review. Okay,
so let's say the person, for whatever reason, is unable. Let's say they've got this back pain from the which requires lumbar laminectomy. They can't be on a cycle for the cardiopulmonary exercise test. What do you do?
So in that case, he will have to have a clinical exercise test.
Like what?
So my understanding is they use I forgot what it is. It's dopamine, I think.
Yeah, you can do a dobutamine stress test.
Dobutamine, with the aim to increase the heart rate and determine if there is ischemia associated to it.
Okay, sounds good. Let's say that the surgeon wants to do this case next week, and you can't book in for a stress test. The patient, let's say the details you find are you found the poor exercise tolerance, but they don't have any other features on examination. So their diabetes is let's say it's pretty well controlled. They're likely to have OSA, but you don't have a sleep study, and there's no CPAP. You've got no examination findings of left or right heart failure on examination. Let's say they're a 10-pack year history smoker, and their hypertension has been managed. The blood pressure has, over the last few readings, is from 120 to 140 on numerous occasions, managed with, say, furosemide. What do? You can't get the stress test soon before the surgery.
Oh, okay. So this is not an emergency procedure. It's purely elective. this patient is stable from the comorbidities point of view. It's a high-risk procedure, relatively high-risk procedure. I think it would be appropriate to delay the procedure, speak to the surgeon, delay the procedure, and organize the stress test.
Okay, sounds good. You delay that, and then they come back to you and pack after their stress test. The stress test was all normal. Now, let's talk about the diabetes. You find out that the patient has been recently started on the ZIG duo, which is dapagliflozin and metformin. How do you manage this perioperatively?
So, as you know, flossins have increased risk of euglycemic euglycemic ketosis.
Yeah, ketoacidosis.
Euglycemic ketosis, sorry. This is a relatively high-risk procedure. I don't expect this patient to be tolerating oral intake straight away after the procedure, especially with his comorbidities, like OSA, maybe pain-related or prolonged procedure might be a bit drowsy. So I don't expect him to tolerate oral intake straight away. So my plan for the flossings will be to withhold the flossings 2 days prior to the surgery, the day of the surgery, as soon as he arrives to PACU. Sorry.
So 2 days prior to the surgery?
And the day of the surgery, so 3 days.
How many hours is that prior?
72 hours.
Good, 72 hours. Excellent. Yeah. So you're withholding the ZIG duo 72 hours. Is there anything else you're doing with that?
You mentioned that his glycemic control, it's relatively good.
On all those medications, it's been relatively good. There
are 2 options. I can give a script for metformin as a single agent, or I can just encourage him to have a low carbohydrate diet.
Which one do you decide?
Given his glycemic control is being good, I will just stop the flossing, the combination flossing for 2 days.
Is there a guideline for this?
Yeah, there's a new. I saw it on the Blue Book on 2019 Blue Book of ANSCA, and the recommendation it's no fixed rule. It's a case-by-case decision based on the glycemic control.
Okay, good. Look, I got to be honest. So our local guidelines just say to start metformin instead of stopping straight off. Let's say if they're on nothing else, then for me it makes sense to continue metformin. But if you can reference a guideline and it's part of you can confidently say that. But also just check on that point, because I'm obviously not an endocrinologist. So our recent meeting with the endocrine, they pretty much have said switch to metformin, but that could be just a local thing, and I won't presume to know everything about that. Okay, good. Let's go with now. You get a call the day before, and the patient's blood sugar levels are greater than 15. So let's say they're 16, and the patient wants to know what to do about that. What do you do?
So his current regime is just metformin plus the flossing. Is that correct? Nothing else? No insulin? Nothing else?
Yeah, nothing else. Literally just on the ZIG duo, which you've now changed just to metformin.
So it's one. I will assess the trend of this. If it's one-off,
it's just one-off.
Just one-off, and they're usually asymptomatic. I will encourage just to drink fluids and check his sugar levels 1 hour after. Also, I will check the time of this reading. If it's immediately postprandial, it's not as bad as fasting. I will encourage to drink fluids and check his reading again in 1 hour before doing something else.
That sounds good. Let's say the other readings are fine, and you decide to then proceed for the day of the operation. Now, let's say, what makes you concerned about this patient's airway? What are the things that make you worried about the patient's airway?
So a BMI of more than 50 is an independent risk factor for difficult back mask ventilation and difficult intubation, and also difficult front of neck access. So everything around this patient will be difficult. I will look for other features like a broad neck, the dentures. If he's got a BIA, I will encourage him to shave his BIA before coming on the day.
Okay, that's good. Now, let's say you consider all these things, and the neck circumference is great, Do you have a number for neck circumference being?
Yeah, for male, it's more than 42 centimeters.
Fantastic. And this male has a neck circumference greater than 42 centimeters. His BMI is greater than 50. So you've identified all the, you're worried about this patient's airway for those reasons. Let's say for everything you know now, the patient arrives, everything else is stable, blood sugars are fine, and you're about to proceed with the anesthetic. What is your anesthetic for this patient who's having the laminectomy?
Okay. So I make sure that I have adequate monitoring. For this patient, I will have an airline preemptively. I will make sure that he's got 2 large bore cannulas in the hands. I will perform, depending on his high risk of aspiration, which I expect him to be, given the lab banding, I will perform a rapid sequence induction, and my technique for this will be to ramp the patient to make sure that the ear tragus is at the same level that sternal notch. I will pre-oxygenate him with high flow nasal bronze, and I will use a video laryngoscope with, oh, the name has skipped my head. Reinforced tube, sorry, with a stylet. In terms of drugs, I will use alpha-fentanyl 1.5 milligrams for this patient, 200 milligrams of dexamethasone, and 200 to 300 of propofol. I'll make sure that there is metaraminol infusion running.
Good. You do the induction. The induction actually goes quite stably. Patient's blood pressure drops, but you're running the metaraminol, and it does improve. You mentioned 200 to 300 of propofol. What number do you give as your first dose?
I think I will have to see the patient, and you know, you have a good, robust 60-year-old. Yeah, I don't know. Sometimes it's a feeling. I probably should stick to one number. I would say 300, and that's what I will do.
Okay, good. No, just on the cover, that yeah, absolutely. The patient seems robust, but if this patient can't walk for that reason, the patient feels less than robust, 60-year-old with the increased weight, I feel like I personally would err on the side of going to say 150 to 200, then titrate after that. It's safer than saying in the exams, you can't see the patient, you don't have all the other cues, to say 300 straight away for a 60-year-old, even at that weight, it potentially is a bit risky. But let's keep going. So what happens is you've started the case, the patient is in the prone position, the surgeons are well into it, 30 minutes after incision. You're out in the T room, and then when you come back, you notice that the registrar has turned the metaraminol infusion. Now it's about 10 milligrams an hour, so 20 mils an hour, to keep a blood pressure of 95 systolic on the art line. What do you do?
So I will confirm the reading by scanning the monitors, finger on the pulse, look at the canisters, look at the drapes. In the meantime, while I establish a diagnosis, I will start with some temporizing measures like increasing just to clarify,
the transducer is at the appropriate level at head height. You've scanned the monitors. The patient is tachycardic. So let's say the heart rate has been moving up from 60 to start with. Now it's about 100, 110. And blood pressure has been, previously it's about 110, and now the aramine's been increasing and the blood pressure is now 90. You look at the rest of the environment and it looks pretty normal except for that.
So I will give bolus of metaraminol, 0.5 milligrams, and will run fluids, 250 to 5, actually I will give 500 mils of crystalloid, and I will assess a response to this.
You get a response, but then it doesn't last very long. In the next 5 minutes, the blood pressure drops back down. The metaraminol infusion is still very high at around 10 milligrams per hour.
So I'll communicate this to the surgeons. The most likely cause it's hemorrhagic shock or cold bleeding. So I will inquire if something has happened that I can't see from my end.
The surgeons are telling you that their surgical field looks clear and they don't have any concerns here.
Other potential differential are a cardiac event like MI, to anesthesia being too deep, dehydration from fasting. So I will continue, I will increase my metaraminol, which is already very high, give another bolus, request an ABG to look for lactate, hemoglobin, pH to help me with my differentials. I will, as I'm doing this, I will assess the response of my previous
You did mention ischemia. What are you looking up for to rule out that?
So I look at my monitor, I look at the ECG.
Yeah, good. The monitors look actually fine from a ST elevation, T wave, and ischemia point of view. You take the ABG, it comes back pretty quickly. And the HB, which preoperatively was 120, it's now 90.
As 90?
90, yeah.
Okay, so this is a significant drop, 30 units. So I will communicate this to the surgeons. The most likely differential, it's hemorrhagic shock, as we said before, for no cold bleeding. However,
the surgeons tell you that the surgeons tell you that the surgeons tell you that the field looks clear. What do you say to them?
That's obviously not possible. We have clinical context of hypotension, tachycardia, and an ABG that shows a significant drop of blood pressure. So there is something going on.
Yeah. And where do you think the bleeding might be coming from, if it is?
Okay. If it's not a surgical field, I'll be concerned about something intra-abdominal organ affected by the prone position. And
as you say your concerns, the surgeon said, look, one of our nails potentially may have, there's case reports of nails lacerating arteries on the other side. I think we'll need to flip back to supine to try and ascertain what this is and go to laparotomy. What do you do?
Yeah. So this is a critical scenario. This patient is hemodynamically unstable and we need to quickly flip. So I will press the emergency buzzer because I need hands-on. I will aim to stabilize my patient in preparation for the flipping. So increase the FiO2 if I haven't done it before. Continue to give fluids and organize a nice and smooth movement from prone to supine.
Yep, you do that. Keep going.
In the meantime, I will organize blood from blood bank. I delegate someone to get some blood products. I will start running some tranexamic acid. So I'll give 1 gram as a slow bolus followed by an infusion. I make sure that medically he's stable from the coagulation point of view. So he's normothermic. He's no acidotics. If I will increase the minute ventilation if needed be. And the rest is a strict communication between the surgical team and myself, like to see what is the next step.
Yeah, good. Let's say that they go supine. Luckily, there's a vascular surgeon in the next theater who's able to come and assist with the laparotomy. You do a laparotomy after the surgeons have packed the back, close it up, and they're safe with the back operation. And they do find a lot of blood retroperitoneally. Good. Now, just because we're after structures, if you were to structure headings for how you have to manage this crisis, how would you structure those headings? Because you've actually given me a lot of those already, but just as a reiteration, even for the audience to see how you were thinking about that in your mind, how you do this in real life. What are your thoughts?
I'll probably say what the issues are. The patient hemodynamically unstable. What do I need to do, which is proning, and who do I need, which is vascular team, blood bank, and preparation for a laparotomy.
That's great. That's actually a really good classification. In my mind, I was thinking the same thing. Look, there's a very concerning situation because it's a potentially massive hemorrhage requiring massive transfusion. I've got a patient that needs to be flip prone. I need to get other staff, vascular surgeon, extra team. And then I need to manage the hemodynamic instability, which is a whole thing in itself, and blood transfusion, massive transfusion, which is, if you were to then, if I was to probe into the massive transfusion, tell me all the elements of massive transfusion that you would organize.
Okay, ideally, I will. You mean as a massive transfusion protocol? What I will organize?
Yeah, like broadly speaking, like, what are the things that you do for a massive transfusion? Just talk broadly about it.
Okay, for massive transfusion. So it has to be a senior person who makes the decision. I will contact blood bank and I will request the NTP to be actioned. The NTP consists of 4 units of packed cells, 4 units of FFP, plus a unit of platelets. My goal will be to do the second MTP to be goal-directed therapy. So I will, as I am starting transfusion, I will organize a routine for a more goal-directed therapy approach.
Is there any other devices that you can ask for? Any other equipment?
You mean tech, which is same as
yeah. So I definitely agree. Use a Rotom, point of care, and repeated ABGs. Absolutely. Any other equipment that might help you
so a cell saver will be very useful.
You will. Anything else to get the blood in quickly?
So you need a level 1 rapid infuser.
Fantastic.
Make sure that is adequate access.
Good. And that's the end of the Viva. Stephany, that was really well done. I think your categorizations were really good. And just to go through it, so firstly, how do you feel?
I feel nervous. I think, no, I knew it would be difficult. I felt it. It's a bit of pressure being on YouTube.
Oh, absolutely.
I thought if I can do this, I can do the exam, and this will be.
Look, I think you did really well because you didn't actually sound nervous. So I think I think that was really good. And trust me, I get nervous when I get Viva as well. So it's fine. I just recently recorded a Viva, and I said hoarseness of breath and shortness of voice. I can't believe I said that. Anyway. So the good thing about this, you told me you gave me a good definition, and then you told me what you wanted to know on assessment. And so the good thing is you went through each of those, and you said, for diabetes, I want to know this, 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 and this. And so the thing that you did well that other people don't do is you listed off lots of facts very quickly. So I want to know about the condition of the diabetes, the severity and stability of it, which means what's the control like, BSLs, HbA1c, micro and macrovascular complications, what's the treatment? And that's kind of it. I've listed those quickly, and I've given I'm not taking a lot of time to go through what is a very long question. Your framing as well, because I think you would have said something like, I would want to assess each of these conditions or something like that. That means that the examiner knows that I'm going to go through these in detail. And when I was in the exam, I had a similar situation where I had an obese patient with lots of comorbidities. And I really thought, does the examiner really want me to go through every little thing? And so I said, okay, this is the game. I'm going to play this game. Let me tell you about each of the things, but I'm going to tell you what my structure is to start with. I'm going to assess each of these very thoroughly. Pause, diabetes, blah, 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 severity, stability, facts, 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 facts. OSA, is it diagnosed? Like you said, sleep study, are they on CPAP? And the one extra thing, because I've got my severity, stability, cause, complication framework, I'd say, and is there any obvious complications of this, which means, signs of pulmonary hypertension, heart failure, etc. And I can delineate that, and then you can correctly ask for an ABG as well. So that was good like that. And room air sats you'd normally get as well. Smoking history you did, fantastic. And then you mentioned very accurately, every lap band patient I've ever had has had a full stomach. So I'm glad you did a rapid sequence. We asked you a question about the stress test, and there's plenty of people, I think, and again, I'm just one person giving an opinion, but I feel like plenty of people would have gone ahead with it, and plenty of people would have tested because you had enough reasons to test the stress test this patient. I'm glad you erred on the side of stress testing because it is elective. This is, you want to probably have the most cautious, thorough approach in this exam. So I think either is fine, but I think it was very fair that you wanted a stress test. We talked about the Zig Duo. Separate them out, give metformin, cease the Zig Duo 72 hours prior, and then contact endo, check the ketones on the day. If you've got blood sugar levels, your answer was very pragmatic, which is exactly what our policies say. So, one blood sugar level greater than 15, not a problem. If it's more than 2 readings above 15 in a 24-hour period, then you really need to seek medical advice, whether go to the GP and maybe up the metformin or do whatever change that's reasonable as well. So that was good. Then we talked about the airway. You had some really great facts about neck circumference, BMI being an independent difficult LMA and back mask ventilation, correct, which is good. And then we talked about the plan, and you literally went into the points of difference and I wasn't bored by what you said. So what do you want for the anesthetic? Great, I need a rapid sequence induction for this, which I'm going to use these drugs for. I'd have an extra monitoring with an art line. And maybe I would have mentioned the extra padding for the face and the eyes, but because it's a prone case, that's the only other thing I would have added. And then the crisis, I think you handle it really well, because so you did the safety steps, check the reading, tell the surgeon, check your monitors. I gave you information about that, which helped you to proceed. You temporized it with volume and more aramine, fantastic. Then you gave me differentials, and then you chased the differentials. You said, I'm worried about hemorrhage. The surgeon says it's clear, fantastic. I'm still going to get an ABG, and now you got your reading. So the one thing I would have added, that was a great structure that you did for the hemorrhage. And then for the, I'm worried about ischemia, so I would check the ECG for any ischemic signs. So every time you give a differential, say what you do to check it, because that's what you do in real life. And then we got to the point of, okay, there is a coupling. And I'm pretty sure this was a case that actually happened at some stage in Australian anesthesia surgical practice. So, a lot of these cases will come out of actual things that have happened potentially. So I don't know any details about that. That was passed down over time. But this is one of those really peculiar, difficult diagnostic elements, but you got there because you searched for it. You gave volume and you gave an ABG. If you had just taken the ABG without giving volume, I would have given you a normal HB, because you haven't seen the dilutionary effect of it. So that's great that you take an ABG, you take the HB value, but that must be in the context of resuscitation. Otherwise, your reading will be the same as a normal patient. And then we talked about what happens at the end in terms of priorities. So Stephany, really, really well done. I think the audience will really enjoy just having heard that and seeing this discussion as well. So thanks a lot.
No, thanks so much for your time, and it's great. It's been great.
No, not at all. Okay, so I guess we'll get a close. Any questions before we go?
No. That's really good. No, that's really good. It made me feel better that you also get nervous. The fact that you say you also get nervous in front of the camera.
Oh yeah, absolutely. And to be honest, I'd be so rusty doing an actual Viva, trying to get out facts now, because I have to, I've got my notes that I refer to. I don't have to memorize things in the same way that you guys do. So, yeah, that'd be difficult. Anyway, thanks everyone for watching and listening. Hope this was useful. Please share with anyone who might be interested, and we'll see you next time.